The term for it would be called population health, and it's a different way of looking at the work you're doing as a physician. But it requires certain things that were not in place until about 5 or 6 years ago. The most important thing that population health requires is an extremely robust electronic health record. In that record, you have a tremendous amount of data available to you that you can use to analyze how well you're doing the job that you're doing. Previous to that, physicians would look at their work and they would see the patient in front of them. They would work with that patient. They would do their very best. But that would be as far as it would go. So every day they come to work, they'll see 20 patients, and 20 times a day they're going to do their very best. And for the patients that are in there seeing the physician, they're getting good care. But there's a terrific proportion of patients that are not coming. They're not in front of the patients. Normal people are asked every day, and as we grew up, they're asked every day, hey, how did you do in math class? How did you do in school? What kind of grades did you get? If you asked a physician of all the patients they take care of that have hypertension, how many of those patients actually are meeting their goals? In other words, would you give that physician a rating of an A or a B, a C? What rating would you do? And physicians were unable to answer that question. There would be no way you could ask me, Dr. Hines, at the end of a week, you've seen 100 patients, they all had hypertension, what percentage of them did you actually accomplish your goals? I couldn't answer the question because I'm seeing each patient individually. I never had a way to look at that question that way, although it's extremely important. So now with all this data that you have, I can actually, because of the robust information in electronic health record, we can start diving down into that. So I can find all the hypertensive patients for the clinic. I can narrow that search to find all the hypertensive patients that I'm responsible for. I can narrow that to every single individual patient that is, and I know who they are. And then I can narrow it yet again and all the way down to what was their blood pressure. So now when you ask me, hey, how do you do what you do? I mean, what percentage of patients that you take care of who have hypertension have reached their goal? And I can give you exactly what that percentage is. Patients might get phone calls or letters saying, by the way, we can tell from the review of the electronic health record that you haven't had this or that or that. So from the patient perspective, they may be receiving phone calls and notices from their physicians that they wouldn't ordinarily have gotten or are not used to getting. But we are not waiting for the patients to come in. So even though our patient's out living their life, we're down there in that electronic health record finding out, is that patient been optimized as far as we can tell. So that would be very different. And we make outreach calls every day now. And that would be one change. The other thing that they might see is when a physician walks in their room, we carry in this point of service tool now, which we never had before, but we've had for about 5 or 6 years. And this is a little bit of the mirror image of population health. When you look at population health, you're looking at a whole population and seeing where you're doing. With a point of service tool, you look at the individual patient and you ask where the gaps in care are. So it's a bit about the mirror image. But because of the electronic health record and the robustness of it, we run reports every night before our patients arrive. And when the physician walks through the exam room door, they have a report in their hands telling us, for this individual patient, they are deficient in this, that, and the other. So the patients will notice that the doctors are just not coming into the exam room and saying, well, how are you doing today? And having an easygoing conversation, checking the blood pressure and shooing them on their way. They're being badgered a little bit. Oh, I see that you have not done this. I see that. You know, I don't have you on this medicine. Why is that? You're supposed to be on the medicine. Is there some reason we don't have you on this medicine? And we're having those type of conversations with the patients, so they will sense that difference as well. I don't think population health is necessarily going to be the end-all be-all, but I really do see population health as a mechanism for us to really step up the quality of care given, in this country. It's a real profound improvement. It's hard to compare yourself locally and regionally because we don't have the benchmarks necessary to make a comparison like that. We do compare ourselves nationally, though, and the information that we have, because we're an accountable care organization, well, the beauty of that is you are provided national benchmarks, and you're provided all the quality metrics for all the groups that you compare with. And we are second, well, we began in 2013 to be an accountable care organization, and in our quality metricing, we found ourselves, surprisingly for us, but we found ourselves to be second in the country amongst all the accountable care organizations in the country on our ability to document the quality of our work.